Okay, this is it, folks. Thank you. Thank you for staying. Thank you for coming out. I think I have it. And again, I want to thank our speakers, Jessica, Women First, Joey, Tom. I want to thank Denton's for hosting us, George for live media. It's beautiful. We have people online watching this. It's really exciting. I went online and I watched some of it. A little bit of a delay, George, no? A few seconds? There's a bit of a delay. The cloud, I'm checking. Okay. We do have the final forms if you would fill those out. If you become a ICUS member, you can send us emails too on what you liked, what you didn't. Please tell your friends and neighbors. I'm going to finish up on something that is also near and dear to all of us. That means you study the heart all the time, but gee whiz, why don't you go 5-6 centimeters up north? Now, Mahala, remember in our echo lab when we did carotids on a routine basis. Basically, what you do is you get a stress echo, you've got your IV, you've got your bubbles, and guess what? While you're there, you study the carotid artery. Why? There are 1 million heart attacks a year. There are 750,000 strokes a year. That's called cardiovascular disease. That's what we do. So if you can take the probe and just move it upstairs 5 centimeters and look at your carotids, you can predict death. Ready? Let me begin this. I'll show you how. All right, we can take contrast and ultrasound anywhere in the body we want. It's very easy to do. And we can image what we call whole bodies. But we are cardiovascular imagers, so we should be interested in the heart and the carotid. That matters. And the aorta. Okay. Now, many years ago, we said, we got to find the plaque that ruptures. If you can find the vulnerable plaque using MR, PET, CT, contrast ultrasound, you're going to win the lottery. I'm just going to tell you now, we won the lottery. Contrast ultrasound did. All right, just as a background, this is the carotid. That's the main carotid, the common. It splits into an external and internal. We don't care about the external, believe it or not. This can be occluded and you'll be fine. We care terribly about the internal. And the internal is what feeds the rest of your brain. The external is often collateralized. Okay, this was what year? I can tell you. You want to guess? What year did we start doing stress echoes and then just move the probe upstairs and cross-train our sonographers? Mahala did it, Paul did it, Kim did it, Adele did it. All our sonographers could do the heart and the carotids, limited to carotid, and Mahala also did renal artery imaging. All right, this was 2002. That's why I asked you, Tom, what year did you start this? We're only now 17 years into this. So this is the carotid artery, and I think you can all identify, this is a Chicago patient. Do you see we're 3 centimeters from the neck? You see that long tube? That's the carotid artery in a longitudinal view. Well, most of you can probably touch your carotid artery, okay? Not so here. This is a large patient. You see the artery? You see that little blockage right here? The plaque? Watch. This was a half cc in the arm vein. Here it comes. It's remarkable. That's all it takes. So if you can get up in your labs to say, can we put the carotid probe on? And remember what we said about the radiology applications. Any organ, any agent can be billed for. Can you bill for a carotid artery contrast study with radiology codes? When the answer is yes. Can the bubble makers talk to you about it? No, because it's not FDA approved. So can we be doing this and getting reimbursed? The answer is yes again. We can talk about that more later, but if there's anyone interested, I'd be happy to discuss it. You should be doing a stress echo with the IV and the contrast, move the probe up and do your carotids. Now look, this is a carotid. See this? That's not what you want. That's an ulcer. Now watch how far we go imaging. Most people doing carotids cannot see all the way to the ear, and we can. These are remarkable studies. They're only 17 years old. So why do we do this? We want to see the lumen and we want to see the bifurcation. So this was a most important study. This is way back in 2003. Do you see inside the plaque here? I was sitting reading this at 7 o'clock at night. I said, holy smokes, what's going on? Why do I see bubbles in the plaque? A plaque is a piece of concrete. It's dead. It's like a shoe leather, right? No. Let me just say a plaque is a tumor, like any other cancerous thing. It happens to be made out of atherosclerosis. Now look at this patient. These are all my patients. I know them very well. Look at inside the plaque. It's filled with bubbles. So now, when I've shown this to people, med students, stuff, that doesn't make sense. We are taught a plaque is concrete. No, a plaque is a living object. Now, this is another patient of mine, and you'll see what happens when you give a bad dose of contrast. It dribbles in. No, for carotid, you give a sharp bolus followed by a flush. You want that lumen bright white. And this is sort of dribbling in. This would be good for LVO maybe, but not for our carotids. So we often saved contrast after the stress echo. We had maybe a cc or so left, and we would give a rapid bolus in the arm vein, and we would get this. Now, watch carefully. This is the scary part. Here's the plaque, right? Here's calcium. Okay, so we can all see, uh-oh, that's an ulcer. But I want you to see something. Look in here. There they come. You don't want to have bubbles in your plaque. That means your plaque is alive and very vulnerable. Very scary. That was 2003. Let's move on. This is probably one of the most beautiful images. You see the artery here? Just like a coronary artery, I might remind you. You see the plaque? No, wrong. Here's the plaque. It's called positive remodeling. Do you see where that is? You come from along here. That's the size of the plaque here. And what's it filled with? Blood. This is a patient from Hans-Peter Westkamp. But look, everyone says, oh, there's the plaque, there's the lumen. No, ma'am, that is the lumen out here. That's what happens in us. Okay, I'll show you a little more. This is a young patient from Milan, Italy, has Takayasu's, inflammation. So let's do the echo, let's do the stress test, and let's go upstairs. Holy smokes, look at the whole carotid is inflamed and engorged. That's inflammation. So easy for us to do. This takes, Mahal, what, 15 seconds, 30 seconds? You're not looking to do a full carotid study. You're looking to do just a limited study. All right. Now, this is a patient from the University of Rome. Huge plaque, right? But no bubbles in it. This is what you want. If you have to have disease, you want scarred, old, rotten tissue. How do we get to that? Well, you take your statins, you stop your smoking, watch your sugar, your blood pressure. You can squeeze the bubbles out of a plaque if you reduce all things that cause inflammation. Okay. This is at Rush. Look at this. Little tiny plaque, right? But filled with bubbles. That's worse than the big one that had no bubbles. This is more likely to go on and kill you. All right, we're going to get to that. Now, this is a patient I have seen. She's had 5 carotid surgeries, no strokes. She's had coronary disease. She's had everything wrong. Look at her arteries. See all this stuff? They're very engorged. That is, all the blood is pouring in from around the muscles into the artery because it's very inflamed. Where does this come from? This is back in 1991. This is a patient who died. This is an injection of latex. You see the coronary here. Here's the calcium. Look at wherever there's a plaque, you have new blood vessels surrounding it. It's a tumor. So this is a very nice autopsy study in 91. Says, yeah, this was a pig study from Mayo. Here's the pig normal, CT, micro CT. Here's the pig fed high fat. Lots of new blood vessels feeding the artery wall. And here's the pig put on statins. Very big change. So if we put all humans on statins, could we reverse this? Yes, to a degree. All right, let's jump ahead. This is what a plaque looks like when you go in the inside. This is the lumen is outside here. This is a patient of mine. The core is necrotic like a cancer. And let's move along. Look inside. See the tiny little blood vessels inside here? You know what they're filled with? Red cells. And guess what? Our bubbles are a third the size of this red cell. So wherever you got these little channels, we can see them perfectly. Now we did a study. This is from Rush. The more bubbles you see, a high amount, the more holes you have on histology when we cut the plaques out. So one more thing. Like Tom, we did a pig model. So here's the pig artery, and here's the pig artery after we scraped the artery in the femoral artery to create a nice big plaque. These pigs had cholesterol, LDLs at 600, so they easily created plaques. They're genetically bred that way, called Rapaz pigs. Look under here, just like ours. See the little holes? Here's the red cells. So these filled with blood and we could see angiogenesis. Now, this is a pig femoral artery. Here's the artery like you see. There's no plaque, is there? There's nothing wrong with this one. And this is at 43 weeks after feeding them fat and they had high LDLs. But what you have is before you develop a plaque, you have the bubbles going into the wall of the artery to feed it because it's oxygenated. Oxygen is low. So it's creating a state. And what happens soon after? Just like in this human, this is a young patient with diabetes. Can you see the artery wall here? This isn't normal. You do not see in humans this kind of blood flow in the artery wall. But again, this is a young diabetic who has a lot of systemic inflammation, LDL issues. I talked to this patient, we did a study, and he refused to take Lipitor. This is what it looks like when you do a diagram. The blood comes from the outside in, and we see it right inside the plaque itself. All right, so many papers now have been written. The plaque hemorrhages, this is what causes plaque vulnerability. Vasovasorm is bad. This is the coronary angiogram using a OCT in the cath lab. See the little blood vessels? Same thing. So this is systemic. This is from Japan. They cathed people, and then they did carotid contrast, and they said, hey, the more bubbles we see in the plaque, the more they have coronary disease. It's one and the same. It's a systemic problem. Let me jump a little bit. From Rush, we did a retrospective study. Said, look, if you had a lot of carotid plaques with bubbles in them, you had a past history of more heart attacks, strokes, and death. Fine. People say, oh, that's great. See, that's retrospective. All right. Aha. Just like Tom, who's publishing now in JACC, our best cardiology journal in America, showing you can reverse heart damage, open arteries. We can show you in 459 patients studied in Canada at Queen's University, if you use contrast ultrasound to look at their carotid, and you did an angiogram on all 459. So you do an angiogram, you contrast carotid in everybody, and go forward. And the hypothesis is that the carotid creates a similar mirror to the coronaries. They are the same. I don't want to hear that they're different diseases. Why? They're not different diseases. I can show you right here. The same disease in the arteries of the heart as the arteries here. End of story. So let's take a look at what happens. These group in Canada gave bubbles after the cath, looked at the plaques, graded them. And here's the kick. You see the Meyer-Kaplan scores? This line, blue line, says if you had a score of bubbles in the plaque greater than 1.25 ratio, just arbitrary, at 30 days, you had a higher death rate, heart attack or stroke, than if you didn't have a lot of plaques. So for the first time ever, in 459 patients, if you see bubbles in the plaque greater than normal, and we can talk about what normal is, you have a higher outcome, bad result. That's at 30 days. Can you imagine what it's going to be like at 6 years and a year? This is a captive population. We'll follow them for years. So the point of this whole thing is, and this was now accepted in the European Heart Journal, Cardiovascular Imaging, and it's online published. Jack rejected it, by the way. Okay, let me end with this case. So let's bring it back to what are we going to do on an individual patient? This patient was referred to us a few years ago, 74, he kept having strokes. And so they said, well, let's do the big box imaging, right? So this is a CT, it's a little screwy, I understand, but this had mild plaque seen, less than 25% narrowing in the arteries. And so it read out moderate internal plaque, less than 25%, go away. And he kept having TIAs. Then let's do another one. Here's a cerebral angiogram, which nobody does anymore. And guess what they found? Plaque, less than 25%. So the CT angio and the coronary, or the cerebral angiogram, same thing. And did he have strokes? Yes, he did have strokes, small changes, but new infarcts. So he kept having these strokes. All right, let's go right to the OR. Do you see the artery? It should be narrow. Why is it dilated out like this? Because I showed you what happens, the plaque grows out, not in. And it preserves the lumen, so this is called positive remodeling. This big bulb here should not be there. It should be as skinny as this and then break into two smaller areas. The brain's over here. So this is exactly the picture I showed you from Hans-Peter Westcott, where the artery goes out like this. Perfect. Let's open it up. Guess what's in there? Well, this is the artery wall filled with clots. See the black clots? It looks just like the pizzas that we had today. See the cheese? No, it is. You eat them, they go there. It's nice. And if you had pepperoni maybe, a little extra, they'll go there faster. So when we opened the artery, but look at the wall, I was pointing that out. Only contrast ultrasound could identify this plaque expanding this way. So of course, then we flush it out so it's prettier. You don't see the plaques and the clots anymore, but look at all this junk. Okay. So let's say, of course, and we picked it off. We picked off an ulcer, a penetrating ulcer that was very small, Tom. And that's what triggered us. When we did that, we said, I think you better take him, and they did. As we all said, we're going to be moving to quantification, whether it's going to be AI or just quantification, and 3D has got to come on, because our biggest competitors will be those big boxes that do volumes, okay? We don't do volumes. We do a 4 millimeter slice every time you move your probe. What we want is a full slice with 3D. So let us continue. Our goal now is to do 3D carotid imaging for bubbles. Place it on the neck, look at the plaque, count the bubbles, and then say this patient needs to be treated. So why? Look at here. This is a carotid artery that's almost blocked, but you see here, can you imagine doing a 2D picture through here? You'd say, oh, it's open. But if I did it here, you'd say it's closed. So you can't have that. You can't have that variability. This is now happening. This is 3D carotid imaging. Isn't that beautiful? That's without contrast. So it doesn't help us see the bubbles in the plaque. It says there's a plaque there, which is bad. And that's a bad sign. It's like wall motion. That's bad. But we can take it one step further with the bubbles, like Tom's myocardial perfusion. You got a plaque? Bad. Now you want to see the bubbles in it? One more step. So the goal is, of course, what? 3D. One way to do it is what we call a mechanical scanner. This scans up and down the neck automatically, takes about 3 seconds. And this is what it looks like when we reconstruct it. So this is a human carotid artery. The skin is on the outside, that's the internal, and you see the plaque and the blood inside of it. The more blood you have in the plaque, the more you will have a bad cardiovascular event. How do you analyze it? Same way we do everything else, just at this point, video intensity. You count the bubbles, digitize it over time. So it's pretty straightforward. Okay, so what's the conclusion? Plaque bubbles measured by contrast correlates with adverse outcome, including death. And it will be the way in the future when we do 3D contrast carotid imaging to risk stratify patients, put them on therapy, and follow them. And I'll tell you, when we start doing what Tom's doing for the heart, and you move your probe up 5-7 inches to the carotid, you've got them all. You've got heart attack and stroke, which is roughly 2 million people a year in the USA and 17 million people globally. You will have an early detection system before and after, as Tom does. Many questions, but again, I want to thank you all on a beautiful Sunday in Chicago and the speakers and you guys for coming. Thank you very much. Any last minute questions for anybody? Fill out your forms, get your CMEs. Remember, go online and you can, Linda, correct? If you go onto the ICUS website, we will have these videos posted.
We're going to have select videos and they're all available at no cost. ICUS wants to educate the world about contrast ultrasound, and there's never a charge to access our educational materials. We are able to do that thanks to the generosity of our sponsors, whom we thank profusely for their support, and are very glad to have them here this weekend, yesterday, and today. Don't forget to put your CME forms in at the front desk if you want credit. Join us in thanking our wonderful sponsors.